Darn it. Okay, I guess we're starting. Uh, Wanted to, I guess, first introduce myself. My name's Hunter Limbaugh, and I'm chair of the board of the Diabetes Patient Advocacy Coalition. And I'm delighted to welcome all of you, say good morning or good afternoon, as the case may be, to this brown bag discussion on improving access in under-resourced communities. Now, I'm looking at I'm looking at my own computer here, just FYI. So I'm looking at the slides. I'm not looking. I can't see what what's being shared on the screen. So which slide we're on. So I hope I'm hitting them right. Um, the one I'm looking at now is our mission, which I will not read to you because that's very annoying. You can read it. And then the Diabetes Patient Advocacy Coalition and the Diabetes Leadership Council are, as it says, we're affiliated organizations. And our two presenters today, Alice and Jasmine, whom I'll introduce shortly, are both on the board of directors of the Diabetes Leadership Council, which is the policy shop composed primarily or maybe exclusively of past leaders of different diabetes organizations around the country, American Diabetes Association and others. And DPAC, as most of you all know, is the advocacy arm of the of this partnership between DLC and DPAC. And now I'm going to introduce our presenters, who would be Jasmine and Alice, and also April Gutman with DLC and DPAC. Jasmine, pardon me, Jasmine Gonzalvo is PharmD. You're going to have to look up these other acronyms if you're interested in knowing exactly what they mean. She is CDCES, FADCES, and is the Chris and Teresa Demos Director of the Center for Health Equity and Innovation and a clinical professor in the College of Pharmacy at Purdue University. Her research interests relate to community health workers, cardiovascular risk reduction, and in disinvested populations, integration of the Spanish language into practice in academic settings, and diabetes self-management education and support in the pharmacy setting. She is, as I mentioned earlier, a member of the Diabetes Leadership Council Board of Directors. Alice Thomas is an RDN, and I guess, I don't know if diplomat is the right word, but she's a FAND, a fellow. Sorry, she's a fellow. And is a nutrition consultant for the Department of Obstetrics and Gynecology at St. Joseph's University Medical Center in Paterson, New Jersey. She's received numerous awards in recognition of her work in diabetes and pregnancy, and serves as the vice chair of the Diabetes Leadership Council Board of Directors. And April Gutman is, oh my gosh, tell me if I get this wrong, April. Don't be afraid to correct me. Senior Manager for Policy and Advocacy.
Government affairs. Government affairs.
Government affairs. All right. For both DPAC and DLC, I believe. Yeah. So these are the experts that will be talking with us today. Let me switch over to a different screen here so I get this right. All right. And what I have up next are some heat maps. We just want to kind of establish a little bit of context fairly quickly for what we're going to be talking about today. First one is diabetes prevalence. I think that's the right term. In the United States, obviously, the darker, the worser. And just gives you an idea of the distribution of diabetes around the country. And, you know, as you can tell, it tends to be focused in the South and more rural areas. That's not universally true, obviously, but it's anyway, it's an artifact worth taking note of. And the next one is an obesity heat map, prevalence map, which not coincidentally layers fairly consistently over the other one that you just saw. Not exactly, obviously, but it's pretty clear that there is at least a relationship between obesity and diabetes. And now just want to run through just a few statistics again to just kind of put things in context and to establish kind of the framework for what we're going to be hearing about today. As it says, this slide, diabetes is nonpartisan, means, you know, it doesn't discriminate among based on politics. It affects everybody in the country. However, some communities are disparately impacted. Black adults, 60% more likely to be diagnosed with diabetes than white adults. Latino, Hispanic adults, 70% more likely to be diagnosed with diabetes, and this is as compared to white adults both. Native American and Alaska Native adults have the highest age-adjusted prevalence, 14.5%, which is nearly double the rate of non-Hispanic and white adults. 38% of US adults have prediabetes. Awareness of that is very low across the board. However, the awareness is even lower among marginalized populations. Black Americans are 2.5 times more likely to be hospitalized for diabetes-related complications, 3.2 times more likely to experience end-stage kidney disease, and up to 3 times more likely to experience diabetes-related amputations. And Latino Hispanic individuals have a 50% higher death rate from diabetes compared to non-Hispanic whites. And not coincidentally, I think, given the statistics you just heard, advances in diabetes care are not shared equitably, I think is probably the right word, across the population, the diabetes population, with Black and Latino individuals being less likely to be prescribed newer, more effective diabetes medications, also less likely to receive insulin pump therapy or CGMs, continuous glucose monitors, even when those statistics are controlled for insurance status or income. So you know, you can't just blame it on that. There's something else going on, or another constellation of things going on that need to be considered. And it's the consideration of those things that we will now turn to. And in doing that, what I want to do is just throw out a couple of questions. Let's see, I need to try and, oops, what happened there? Okay. I'm still on, right?
Yeah.
Okay, good. I don't know what happened here. I'm not seeing anybody. Okay, I'll try and sort that out after we get into this. Anyway, so this questions are for Jasmine and Alice. Oh, there you go. Sorry. All right. In your experience, what have you seen that can give us some context for the numbers that we just saw? Let's just go with that first one, and y'all can jump in however you'd like.
I can start. And I see some friends who I know in the participants, and I'm sure that they have a lot of content to add here as well. So I don't want to just preach to the choir, but essentially, I think all of us could probably name right what's going on and what's contributing here. So I think an obvious one is medication costs and populations being uninsured or underinsured and being unable to afford medications. That with and that problem probably growing for more and more people. If we see people losing jobs, more people needing Medicaid, for example, to help pay for medications, or being, having a job that doesn't have sufficient insurance coverage to help pay for all of the medication costs. I think all of those, on top of what may already exist in terms of systemic barriers, like, um, you know, things that contribute to lower health literacy, transportation issues, language or cultural barriers, all of those that have persisted, on top of the idea that maybe we have a growing inability to afford medications. All of those, I think, are the biggest contributors that I've been seeing, both across a number of different populations. We have rural populations, we have immigrant populations where there may be similar barriers, for example. So maybe transportation or lower socioeconomic status may be, shared barriers. And then for immigrant populations, you put on top of that perhaps cultural and language barriers on top of that as well. So not a shortage of barriers and disparities in this space, particularly when it comes to cardiovascular risk and diabetes.
Thanks, Chet. Yeah. I was gonna say, Alice. Yeah, and you kind of got into, and I'm glad you did. Just the second question I was going to ask, which actually, what are some of the barriers? So, Alice, feel free to just kind of follow that lead.
Sure. Well, when I practiced, it was mostly with pregnant women, and what Jasmine said was so true, because it's so complex. And when you go back to look at the statistics that you mentioned, it's sad. And for the most part, we have to ask ourselves the question, why there are so many more health disparities in the Black and Hispanic and immigrant population. And it's not one size fits all. You cannot have a health system that where everything is equal. I may need more services than what Jasmine has, but if you have a system that just gives everyone the same thing, I'm not going to get the same health outcomes that Jasmine would have. And in my experience, I used to work with patients that had no income, that were homeless, to women that had seven-figure income. And I'm thinking of one in particular that she wanted to know how her blood sugars would would be flying from Los Angeles to London, England. And then you had someone who did not know where her next meal was going to come from. So there are a lot of factors, the social determinants of health, and we can never forget that in dealing with the patients. And we're not going to move the needle per se unless we deal with those problems that were mentioned in the statistics. Hunter, you are muted.
Yes, I see that. Sorry, thanks. This was for Alice. Primarily, I mean, I think Jasmine hit on some of them, but could you maybe just talk some more, if you can, about what in particular some of the barriers are that you saw in your practice? I mean, just kind of flesh that out just a little bit, maybe.
Sure, some of the barriers in terms of Medicaid, because we were a regional center where I worked at. If we had patients coming from New York, their Medicaid was a lot different than New Jersey's. And if they came from some other states, I've seen at times when women would move back to New Jersey because the coverage that they had in their particular state would not cover everything that they needed in their pregnancies. Jasmine mentioned transportation. If you have a woman who lives 50 miles or more away, and we would have that, maternity hospitals are closing and obstetric units are closing. So again, if you have someone who lives maybe 50 miles or more away and she needs transportation to deliver her baby, those are the types of things we see. With the supplies, with the devices, those things that the woman would need during her pregnancy, and they weren't covered either by Medicaid or by her insurance. So we would have high deductibles. We would have women who would come back. We would give her a prescription to go to a pharmacy. And 2 weeks later, we find out that it wasn't filled. And in pregnancy, you only have a short period of time to do whatever you need. So those are the types of things, those are the types of barriers that I would see in practice.
And then my impression is that there are a lot of misconceptions, both, I mean, in the public and among policymakers, about under-resourced communities and misperceptions that can actually get in the way of people getting the care that they need. Can you talk about that at all? Do you think that's accurate? Do you think there are misconceptions? And if they are, what they might be and how they actually, what role they may play in getting in the way of people getting the care they need?
Yeah, I think there are misconceptions about a lot of people everywhere. So yes, definitely under-resourced communities aren't immune to that. And I think perhaps some of the most stigmatizing I hear are sort of, that there's a lack of motivation to care for themselves and for diabetes. That there's a dependency on free services as kind of like a handout. Um, and and these sort of, the way that we can kind of frame that is sometimes from a healthcare provider perspective, that it's an implicit bias. I think you're not going to use this CGM. I know you're not going to want to do insulin. And then that plays out, right? That plays out as people not receiving the care that they need, deserve. That may play out with, I'm not even going to talk to you about a CGM because I assume that you're not going to be able to use it or afford it, or any sort of assumption right there. And I kind of use an approach of when I'm working with people, I have this sort of this is my own personal opinion, I have this CGM for all type mentality of like, I'm gonna ask and then we'll figure out the rest later, right? Because I do think CGM can be an effective intervention for changing behaviors in a lot of different people. And even at where I work, we looked at the use of CGMs, particularly in a Latino population, and we found that there was 100% of the people who we were studying here were filling the CGM, And that is inconsistent with, I think, some of the narrative that's out there of, like maybe a language barrier, or kind of referring back to that laziness thing of not wanting to care for themselves. We found 100% of people were actively filling the CGM prescriptions. And so for me, uh, working with people with diabetes, I really like to say, like, ask about CGM, ask about CGM, ask about CGM, because if there is any sort of those implicit biases that I have, or even just forgetting to ask, it's just unfair to people in general, not to at least explore what the access may be. And sometimes that's even me saying, like, I'm not sure if we can get this, but would this be of interest to you if we're able to get it, right? So I think that there's a lot of stigma around diabetes, around certain populations that do have an impact on the way that the healthcare team may even interact or approach. And I think that that's on the healthcare community to overcome, recognize and overcome a lot of those barriers so that we're not creating disparities. I would also love to encourage people with diabetes to advocate for themselves in these spaces of saying, like, why haven't we talked about CGM, or is this something that we can explore, insurance coverage for, or why am I paying this much for this treatment, and asking those questions to just ensure that your healthcare team is really doing the best that they can, and not just chalking this up to, because sometimes it is, as on the healthcare team side, you have to put in a prior authorization, you have to jump through more hoops, there's more documentation to get people access to some treatment, some technology. And it is our responsibility to do that for everyone, right? So it may be an additional workload for the healthcare team, but I would encourage people with diabetes to sort of push the envelope in those spaces if you'd really think that you need access to one treatment or device.
Can I, before I turn to Alice, just something that you were talking about there, Jasmine, that really kind of struck a chord with me, and that I wanted to ask about, and this is off the top of my head, so nobody's prepared for this, but anyway, when you were talking about your own implicit bias, or unconscious bias, or however we want to kind of define it and think about it, two things occur to me. One is that all of us, it's something all of us in a perfect world are thinking about all the time, and interrogating in our own minds about what may be there that we're not always aware of. And I'm just curious, and this is the question, I guess, because we're not going to be able to solve all or any of these problems today. I think mostly we want to highlight them and let people know that they exist who may not know they exist. But what role, if any, do you think may not be being appropriately served in education of healthcare providers, physicians, PAs, nurse practitioners, the whole gamut of people that see people with diabetes and any other disease state, frankly, in recognizing the importance of that, and not letting the cultural pathologies sometimes that exist seep into their care?
Yeah, I think we're doing a better job talking about it, right? Like telling people this is what implicit bias is. This is something that you have. I think where we have opportunities is really creating a safe space for people on what to do about it and how to talk about it. And also, like, so for example, I think where there's a steep drop off is, okay, I have this stigma, and for example, I don't think this person knows how to use a CGM or will navigate a CGM well, right? Now that I've recognized that I have that, I actually need the tools to if I then take the step to have that conversation that, I really think you need a CGM. What I'm also seeing in primary care is like a lack of provider education on like how to read a CGM report, right? And so I think that there's also an opportunity in the healthcare space of like, you know, addressing some of these barriers comes with some insecurity of or literally not having the tools on how to navigate improved medication access. So as a pharmacist, a lot of times it's like, you know, I feel for the primary care providers who may be like, I want you to have access to this medication, but I'm not sure I have the time, the wherewithal, the resources, the knowledge to navigate all of the barriers that you have to getting or accessing these medications. I may not even be working with a pharmacist who can help me in this space. So Hunter, I think the comprehensive answer to your question is what I think has improved in healthcare professional training is like implicit bias exists, sort that out, give yourself time to explore and recognize that within your own personal, you know, kind of care that you provide. We do need to keep on following that with the training and the resources of literally what to do with sort of when you find yourself in those spaces encountering operational barriers to improving care as well.
Great, thanks.
I just want
Alice, jump,
to,
yeah.
yeah,
Go
I want to attach to that because I see in a lot of times in practice, especially with dealing with pregnant women, about 80%, maybe 80 to 85% of the women with diabetes and who are pregnant have gestational diabetes, meaning that they've gone through 24 weeks to 28 weeks, everything was fine. And then all of a sudden, they develop gestational diabetes. Most of their care is coming not from any kind of diabetes specialist, but from OBs who don't have that particular specialty. So getting back to what you said, Jasmine, and also Hunter, is that, yeah, it is a provider thing too. So it's not only implicit bias, which does exist, but also if the provider does not have the education. And if they are not familiar with a particular product like CGMs, most OBs that I know nothing about CGMs at all. So they are more than likely not going to recommend a CGM or some other types of devices, whatever, for a pregnant woman if they are not familiar with the product.
ahead. Yeah, I think I mean, I was gonna ask specifically about stigma, but we've met, it's been mentioned. I mean, and but it seems to me that there's like, they're kind of um, two elements to it, I think, and maybe I'm not right, but you know, the problem of stigma, and it can be either stigma around of having diabetes, around, you know, weight issues, obesity, you know, even the stigma that I know that some people can feel wearing, you know, visible devices on their bodies, for instance. But, you know, so there's this, it seems like that stigma can play a role both, you know, personally with the patient and then in society at large. And you know, they're kind of different issues. But do either of you have anything more that you wanted to talk about in terms of you know, the problem of stigma, either external or internal, to put it one way?
I do have a little bit of a soapbox. when I
Okay.
have a lot of soapboxes, but one stigmatizing statement that I hear often that I just like to throw out there because I think I've heard it a lot and is so actually it comes up around like mental health and people there's a whole spectrum of mental health, right? From depression to serious mental illness, right? And people with diabetes fall anywhere along that spectrum, right? But one of the most damaging things that I've heard is you can't treat the diabetes until you treat the mental health. And it gets under my skin when I hear that because when is mental health solved or cured? And in that space of waiting for mental health to be solved or cured, the 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 risks and complications for, from higher sugars, for example, are putting the person at risk, right? So we have a stigma here of, um, particularly as related to people that do struggle with mental health issues, that you find yourself in a stigmatizing space of, okay, well, we're just going to ignore my diabetes while I figure out my mental health. And as the healthcare team may all be sort of playing into that sort of stigma, in which case there's a very complex set of complications that are waiting for people that are struggling with improving their mental health. So I do think that the healthcare space needs to move away from that idea of waiting until mental health has improved to a certain level to address anything that needs to come with diabetes. I think there are conversations and ways to communicate that can still advocate and support for improving diabetes health in the context of someone who's struggling.
You
Right.
also see that kind of stigma with obesity, especially in women. And when they become pregnant, you cannot separate the three of them. And again, seen in practice where they try to not deal with the obesity at the time, try to deal with the diabetes, but not dealing with all three issues. And you
Well,
can't separate them.
that's a pretty good segue, I think, into the next thing I wanted to ask about, and that's what what specifically or generally, however you want to approach it, gaps in care exist. In other words, what kind of what's missing in the care model for dealing with under-resourced communities? Alice, why don't you go first this time?
Okay. Well, I think we mentioned some of them, that there aren't enough specialists in diabetes care. I looked up to see just how many endocrinologists are in the country, and it's about 9,000. And there's 38 million people with diabetes. So again, there's not enough endocrinologists, there's not enough diabetes educators, there's not enough nutritionists to take care. So that's one of the problems. One of the other problems that I've seen with gaps is the whole issue of housing, um, transportation, food deserts. People who are living in areas where they don't have uh, affordable foods. And the only thing they have are fast foods or convenience foods. So we get into the whole area of food deserts and food swamps. So, a dollar menu or value meal versus paying, $9 right now for a dozen of eggs or $5 for lettuce. Those are the types of things that we're seeing.
Yeah,
And I would assume pharmacy deserts are another growing problem.
All the deserts, all the
All the
growing
deserts.
deserts
All the
are
Yeah,
problematic. And
yeah.
I see that my friend Artis Reed is on here, and I am gonna preach to the choir to Artis here for that. Support for community health workers is something that I think is an opportunity that exists. So for anyone not familiar with the community health worker workforce, it's really people from the communities supporting people from the community. So, the best example just happened this week. I was teaching a group diabetes education class, and this woman joined, and she was just recently referred to a nephrologist for her kidney care because she was having all sorts of complications. She was having a ton of neuropathy. Her feet were burning, all of these things. And she did her thing in that group education class because there were these two older guys who were kind of like, I feel fine. And, like A1Cs of 9 or 10, something like that. And weren't really engaged in their care. And she said, she basically, proverbially slapped him in the face and said, you guys don't even know. You have the opportunity to, take care of yourself. Don't end up like me. Don't end up on dialysis. For years, I didn't care. And here I am, blah, blah, blah. Right. That is sort of the magic of a community health worker, of someone who can connect with the community. They may have lived experience of that community. They speak the same language. They have similar cultural preferences, those types of things. And we have a lot of evidence base to support community health workers. And I think the diabetes community in particular has a real opportunity to engage with community health workers when you need some social support, for example, of, you're having a tough day, you want to eat things, you want to live your life, and diabetes is holding you back. That community health workers are a fantastic workforce that we should provide more support for those moments of when the diabetes journey is particularly tough. That the healthcare team right now, as is the traditional healthcare team, doesn't provide sufficient support in those moments. And so I think the community health workers really have a huge opportunity there. I also think, again, from a pharmacist perspective, we don't have enough resources for the healthcare team to help manage medication access and barriers to medications. And so when something is unaffordable or there's some insurance hiccup to navigate, I don't think that there are sufficient people who know or have the time or capacity or resources to navigate all of the hoops that it takes to get somebody access. And I know that I find myself in that situation a lot, where the person with diabetes really just says, I couldn't get that medicine for whatever reason, and I don't really know why. I went to the pharmacy and they said I couldn't get it. And then I kind of pull one or two levers my go-to levers that I pull, and then we get them access, right? So I think more broadly, people don't know what those levers are that need to be pulled, or the questions that need to be asked, or who to talk to, or, all those things. And so I think that that's an opportunity as well that doesn't really exist. The structure doesn't exist to support providing that knowledge. So my short answer, Hunter, is community health workers, I think, could use a lot of support, and is a gap that could be filled. And then more medication access resources for people to navigate to more affordable resources for medications.
I would also add education for providers who are not diabetes specialists. That's sorely needed.
I'm going to give a little prompt here. I mean, one of the things that we have been concerned with in recent weeks in particular, but I mean always, but it's really kind of gotten to be an acute concern, is the Medicaid issue. Can either or both of you say something about the role that Medicaid plays in with these populations?
I have a go-to story with a Medicaid person on Medicaid who I was working with, that essentially she was on Medicaid and doing really well. Her A1C had come down a lot. I want to say it was something like 3 percentage points or something like that. And when she got a job, she was unemployed on Medicaid, and then she got a job, and then she was underinsured and couldn't afford her insulin. And so she was actually stuck between a rock and a hard place of having a job to be able to pay for everything else in her life, or not having a job and being on Medicaid and being able to afford her insulin, but obviously lacking sufficient income for her other needs. I think there's a lot of room for improvement in supporting people to have both. And that was one. I mean, and I didn't know how to help her in that situation. There was very little that I could do, and all of the levers, I was just mentioning weren't working for her or didn't have a chance to work for her. So I think that Medicaid really does need to be robust for people who find themselves unemployed. And if we see unemployment numbers go up, medical debt is going to rise for a lot of people. People aren't going to be able to take medications to receive the care that they need if they're unemployed. And so we need a robust Medicaid infrastructure to help support those people, so that their health doesn't tank, while they're on the search for an gainful employment and good insurance coverage. So I worry that if we have kind of a weaker Medicaid infrastructure, that a lot of people are going to suffer.
And also there's the inconsistency with Medicaid among the states. I'll give you an example. In New York, they cover cost of pregnancy care, even if the person it doesn't matter what their immigration status is. But in New Jersey, they will cover for US citizens and for anyone that has a legal status. So for the woman who is illegal, she's going to have to go through hoops. And I know that we had to go through hoops in order for her, let's say, to be able to get, we're not even talking about CGMs, but just a blood glucose meter to monitor her blood glucose levels even one time a day or twice a day, because she could not afford the strips. So it's something that is inconsistent across the states. And I think I mentioned it before, that we had patients that actually moved. They would move from state to state trying to get better prenatal care.
One thing I'd also, and let me just say one more thing, Hunter. I think,
Yeah.
Alice, you bring up a really good point in terms of inconsistency, because I there did I just lose my point? Hold on one second. Hold on one second. It'll come back. It'll come back. It'll come back.
It'll come back.
I got it. So one of the things that hasn't ever made sense to me is, at least where I am, a state Medicaid policy is that, for someone who doesn't qualify for Medicaid because perhaps of documented status, or they get access to Medicaid Package E. Does anybody know what that is? The emergency package, where you have access to the emergency room. So we're not going to pay for any of your primary care to prevent you from going to the emergency room, but we will pay for your most expensive care. That doesn't make sense to me. So we're only going to pay for the care for when things are on fire, for example, right? But we're not going to pay for anything leading up to that fire. And so to me, it doesn't make sense at all that we're basically planning on spending the most money for their care, versus wellness and prevention.
Yeah,
It
the
doesn't
whole
make
system's
sense at all.
irrational.
Yeah, it doesn't make sense at all to not pay for a person not to go to the emergency room. It doesn't make sense to not pay for services that will stop a person from eventually having to go for dialysis, or avoiding amputations. It just doesn't make sense to me.
It doesn't. I mean, we've been fighting that,
Yeah.
that irrationality in private health insurance forever, that pay me now or pay me way more later. And it just, I don't know, for some reason that just doesn't get through, but we need to move on, real quickly, not real quickly, but we do need to move on. And I wanted to turn to April, now, and just kind of let April get into some of the issues around what role policy plays and what DPAC's doing, and that sort of piece of it.
Yeah, absolutely. Thank you, Hunter. I think policy is a really important piece of the puzzle when it comes to improving access and addressing disparities. I say that because it's only one piece. Alice and Jasmine have done a great job of talking about all of the other pieces of the puzzle, addressing stigma, things like that. And so to get a policy passed, you typically need evidence. And then once the policy is passed, it doesn't necessarily mean equal access. You have to ensure the policy is implemented. You have to educate stakeholders, and make sure that people know they have access to things. But policy is sort of that, often that first step in underserved communities gaining access. For example, the Medicare program provides health insurance for over 67 million people, and the Medicaid program provides insurance for almost 80 million people. Medicare is primarily for individuals 65 and older, but also covers some other groups like people with disabilities. Medicaid is a joint federal and state program, but mostly administered by state governments. It provides coverage for children, pregnant women, elderly adults, people with disabilities, low-income adults. And, in each case, it's the state or federal government that determines what they're going to cover and for who, under these programs. So you have to get policies in order to get coverage. For example, each state has a policy for whether they will cover continuous glucose monitors, what conditions you have to meet, which devices they will cover. And so getting coverage for certain populations, such as people with type 2 diabetes on insulin, requires advocacy in order to update those policies. And that's something DPAC works on consistently, is access to medications and devices through our policy work. So, I think policy plays an important role in the grand scheme of making sure that people have access. But, you still need to make sure that those people are able to see a provider, and that they know they have access. And that leads to another policy issue, which is making sure that diabetes care by providers is paid for appropriately, so that these Medicare and Medicaid, because Medicare and Medicaid also decide how those people are paid when you go in for an office visit. And so ensuring they're paid appropriately for their time allows them to keep their practices open and to keep seeing patients. And without them, the patients are the ones that are left without a provider, typically in underserved, especially in underserved and rural areas. So there are a number of policies I could talk about. Hunter, I don't know if you have another question for me, but I did want to talk about our work specifically on Medicaid right now.
Yeah, no, that's fine. Go ahead. I mean, I don't need to be asking you questions to direct you in a direction you're already going.
Okay, great. So right now Congress is working on what they call a reconciliation bill, and they have already passed that they're going to make significant cuts, and basically those cuts will have to come from the Medicaid program. And the Medicaid program is truly a safety net program, as I've described, for anyone who might need it at some point in their lives. And most people will either need it or someone they care for will need it. It's not just for low-income individuals. Many states have expanded Medicaid to cover a broader population for some of those people who, may be working but may just not make enough. Medicaid also pays for over 40% of all births in the United States, and for things like long-term stays at nursing homes for elderly people, things that Medicare doesn't cover, so they would have to pay out of pocket otherwise. And then, of course, for people with diabetes, Medicaid helps them afford their insulin, their technologies like CGMs and insulin pumps, and their doctor's visits. So cuts at the federal level would mean states would require a lot more money to cover these people and these services, and most, if not all, states don't have that money. And so that would mean they would cut who is eligible for Medicaid, reduce who they cover for those benefits, lower reimbursement to providers, which would lead to a lack of access, as we've talked about, or increase taxes very significantly. And so right now, DPAC is asking our advocates to get involved because we need everyone's help to stop these cuts from happening. We have a petition we would like everyone to sign and share with everyone they know to show how important the Medicaid program is. And then we're also asking our advocates and the public for stories on the importance of Medicaid if you have experience, and to reach out to your federal legislators to ask that they oppose any significant cuts to the important program.
And I don't know if you're prepared for this question, but is there is there a specific best way to direct people to the petition regarding Medicaid? Is it on our website, or is there, well, anyway, you get the question.
Yes, it is on our website. I believe it's under the Act Now section of the DPAC website under current actions, protect Medicaid, sign our petition. You can also share your story there as well.
Okay, yeah, great. I mean, because that is, I mean, they're like literally as we speak, they're in the process of working through these issues and cuts in Congress. And the more voices they hear, the more likely it is that we'll be able to have an impact on what they do. And one other quick thing, and April, it's fine. I'll just mention it myself because it's something we also are doing, and and this is just a personal thing. It's not a pet peeve. It's way bigger than a pet peeve, but some of the stuff that's been going on out of the administration and the cuts to medical research are, to my way of thinking, some of the most damaging. And this is just me talking. I'm not speaking on behalf of any particular organization. But it's the kind of thing that can have damaging effects that will last literally for generations. We're not talking about just this year, Dr. thus and such isn't going to be able to finish his or her, research program. The cuts that have taken place have ramifications that go way beyond that level. And so if and when you're inclined or you're asked to lend your voices to that issue, I would strongly encourage that as well. Because the scientific and medical research is just crucially important for people with diabetes and every other disease state and lots of other reasons too. But so I just wanted to bring that to your attention. And we're getting close to being at time. And I'm kind of a stickler about staying on schedule for things, but we do have a few more minutes. So I wanted to start the wrap up process and just see if Jasmine and or Alice had anything they wanted to add as things that people can do as advocates just on their own to help address some of these issues, not in the short run particularly, I guess, but just anything you would recommend people doing, whether it's self-advocating, self-educating, whatever, anything you can think of that might be useful in the advocacy world for people to do.
Yeah, I think we are lacking in kindness across humanity right now. I'd love to see more kindness, and I think that that should come out in just kind of like understanding your fellow human being and the barriers that people may be facing. And I think if we can all lead with that, we will be in a better place. I don't want everybody to become so, jaded and sort of spiteful that we're not just looking at each other as humans and taking care of each other. So that's the space I'm trying to stay in.
As for me, I would say for those who are listening, to make sure that you become a diabetes champion. And I was at the International Diabetes Federation conference in Bangkok 3 weeks ago and attended a symposium with the head of the World Diabetes Federation. And he said something during his talk, and I wrote it down and I will not forget it. He said, he used to say that diabetes was too expensive, wasn't a too expensive disease to treat, but he has since changed his tune and he says, diabetes is too expensive not to treat.
Yep, and I would just add to real quickly, and I'm going to ask April if she has any last bright ideas for the good of the order, just in the general advocacy space, but I would encourage folks to pay attention, read the stuff you get from us in particular, and when we ask you, beg you to act to do it. The Medicaid petition is a good example. Yeah, but not necessarily wait on that kind of thing. You know, there's nothing that keeps any of us from getting to know our local legislator. A lot of these issues have state and sometimes local solutions that can be brought to bear. They're not all federal by any means. And getting to know your legislators, your local officials, and paying attention to what's going on in your states that may have an impact on diabetes. And Medicaid in particular is, as was alluded to, it is a partnership between the federal government and state governments in terms of funding. The vast majority of the funding does come from the federal government, but a lot of the funding also comes from the state government. And if and when the feds actually do implement painful cuts to the federal funding, then it's going to fall on the states to try to make up as much of that as they're inclined to do. And so we're going to be needing to talk to the state legislatures about additional funding for Medicaid to try to make up some of the gap that's going to be probably left from federal cuts. So, April, did you have anything else you want to add? And then
Yeah, just to add to your point really quickly, advocacy does matter. Some of the politicians or people who work for them might not admit it, but they don't know everything. They often have so many, like all of us, have so many things going on that you can, when you share your story and your personal experience, it can really make an impact. So I would just encourage everyone to do that.
okay. Well, I think we're pretty close to time. If either Jasmine or Alice had anything in particular, just as closing thoughts, now would be the time. And if not, then again, I'm just going to reiterate that anyone who's listening who has not signed up to be a diabetes champion, please do that. Please visit our website. It's what is it, April? It's diabetes
Diabetespack.org.
Yeah, diabetespack.org. Sorry. And go to the Act Now section and see what the latest and greatest need is, and act now. That would be very helpful. And I guess that's all. Thank you, Alice and Jasmine, very much for your time today. It's been very informative and distressing in some ways, but that's okay, because when we get distressed, it can motivate us to act. And April, thank you for your insights and input, and for all that you do for DPAC and DLC. We really appreciate it. And with that, I'll just say thank you and goodbye, and go forth and do good.
Bye. Bye-bye.
All right.